keeps us distant.
Okay, well, it's obvious I'm not Antonio Colombo because my Italian is terrible. I'm Jeff Moses. Antonio will be joining us shortly. He's still making it back from the cases. We have a very interesting transmission and some discussions really highlighting our colleagues from Bangladesh. And we'll be talking about complex lesions and high bleeding risk patients, which of course is becoming an increasing issue for all of us in our daily practice. So I think are we ready? So we're going to have a transmission from Dhaka. So are we ready to start? I think we're here. Hello.
Hello.
Can you hear us?
Yeah, we can hear you, and good evening, and thank you so much for inviting us over on Valentine's evening. Really appreciate that. So we are here from Bangladesh, and we've got a pretty interesting case line for you. But before I start that, can I introduce my team for you? So I've got Dr. Ashok Jyotatto. We did the case together. Then our chief technician, Morshed, Russell, another technician who's helping us, Sister Lipi and Tanzila, and Ahmadullah, the anesthetic. And upstairs is Dr. Tawfiq Shariar Haq, who is sort of coordinating everything with the tech guys. So that's us here in Dhaka, Bangladesh, from National Heart Foundation Hospital.
Okay. So you have cases for us?
Yes, absolutely.
We have our whole panel here.
Yeah.
So we're ready. We're very interested and ready after a long day of love.
Okay, right. Thank you. We really appreciate it that you're here in this late hour. So we're from the National Heart Foundation Hospital and Research Institute, which is a 480-bedded tertiary cardiac care hospital. And today I would like to share with you the case. So let's go to the case directly. Now, this is a very complex high bleeding risk patient, as you will appreciate. He's 83 years old. He suffered from a non-STEMI 2 weeks back, and he was admitted in another hospital where they did his angiogram. And then he was subsequently transferred to our hospital. He has a history of CVD in 2012, and then again in 2018. He's hypertensive, diabetic with COPD. His creatine level today was 3.6 milligrams per DL. Actually, after the angiogram, he developed acute kidney injury on chronic kidney injury, and his creatinine rose to 7.8. That's around 2 weeks back. After that, he received 2 cycles of hemodialysis. At present, his creatinine is 3.6. He has a strong family history of coronary artery disease. His ejection fraction is 42%. And this is his ECG that was done today. Probably he had an old MI intraseptal. Now this is his angiogram. And you can appreciate very complex lesion, and that's the tragedy, right? With high bleeding risk patients, you have very complex anatomy as well. So he has the left main, especially the ostia of the left main, looks pretty diseased. There is severe, almost 99% stenosis of the LCX, which is rising at a 90-degree angle. Then there is a lesion in the proximal part of the LAD, and there's a diagonal, which ostia is diseased, and then it's a CTO. The RCA is a small-sized vessel, and it is diffusely diseased. So this is the anatomy of the patient, and his syntax score obviously is pretty high, 34. So that is the case. Severe coronary artery disease, and I suppose you can appreciate from the fluoroscopy. Let me show you the fluoroscopy. And from the fluoroscopy, you can appreciate the amount of calcium there is. So pretty much calcified, severely diseased left main with involvement of the ostia of the LCX with a longish lesion in the LCX, and there's another lesion in the LAD. So that's our patient for today. High bleeding risk, 83-year-old with a history of CVD twice, and with a creatinine today of 3 point something, who had to have hemodialysis.
This is an incredibly challenging case. How many on the panel would refer this patient to surgery? I wouldn't blame anyone to call the surgeons first.
Dr. Fazila, do you estimate the syntax score of this patient?
Yes, we just showed the syntax score. It was like 34. So 34. The syntax score is 34.
The
What is
ostium or the left main, when you engage, was there any damping of pressure?
When we engaged, there was damping of the pressure, so we assumed that the osteo of the left main is also involved.
Was nitroglycerine given after there was damping of pressure? And
Yes, yes. Nitroglycerin was given very gently, and after that also there was damping of pressure. So, I mean, the left main, as you can appreciate, looks pretty diseased, and we have a strong suspicion that the ostia is involved, which we subsequently ascertained.
So what strategy you are going to take that regarding considering the angle between the two LMCA angle, LED
Yes,
and LCX
so
angle?
obviously here we strategized that we would need to do a double stent strategy, right? Because the LCX is so diseased, we would have to stent it, and also the LED and the left main is diseased. So for us, we thought we would do a double stent strategy. We would do a decay crush. Now, as you have rightly said, wiring the LCX would be a challenge. So what we did is we took a fine cross with a Sion blue. But initially, we were unable to pass our Sion blue. So we changed our Sion blue to a Pilot 50, a hydrophilic wire. And with that hydrophilic wire, we were able to wire this LCX. Very challenging because it was like 90 degrees. So we really bent the wire, and we were able to cross with the Pilot 50. Once we had crossed with the Pilot 50, we seeing the amount of calcium, we knew that we would need to do rotablation. Otherwise, we didn't want to prolong the procedure. So we decided at the very beginning that we would change to a rota wire, and we did rotablation of the LCX.
You didn't consider an IVUS considering the fact that the lesion seems to be calcified?
Actually, we considered IVUS, but we also felt that this gentleman would not tolerate us putting an IVUS probe through this severe 99% lesion. So we didn't take the IVUS probe at that time. We subsequently took the IVUS probe. So this is us doing rotablation. We first did with a 1.25 burr, and then we went to a 1.5 burr. So it was more like a plaque modification for us rather than aggressive rotablation, because obviously he's a very sick patient, 83-year-old, and we wanted to be as gentle as possible.
Do you want to have hemodynamic support?
As such, he maintained his hemodynamics.
Because it's a complex case?
We have the IBP standby, but apart from that, he was maintaining his blood pressure. We did not start him on any hemodynamic support.
Well, you didn't wire the LED, and why didn't you consider rotablating the LED first? Because it's a straightforward lesion, and the circ has a curved course, and rotablation would be slightly more difficult in the circ as compared to the LED.
Yes,
and why didn't you wire the LED for doing?
The thing is that at that moment we thought that the LCX was the most challenging and the most complicated lesion, and this was the lesion that was really causing him trouble. That was our impression, and so we decided to tackle this lesion first, and that's why we did rotablation of the LCX first. And as you say very rightly, LED was a straightforward vessel. Doing rotablation of the LED would have been much more easier. I totally agree with you.
Yeah, so that would have given you much more support once you would have rotated the LED.
But the LCX ostium is very critical, so she may lose that LCX after.
Exactly, my thought exactly. You see, the thing is the LED was there supporting us. It wasn't really causing any much harm or any problem. But if, like, while doing rota of the LED, if we ran into any trouble, this patient would not have tolerated that. So we wanted
the advantage of doing a rota is that the chances of losing the side branch are much less, because the plaque shift and all those things would be much less when you're doing a rota.
Yeah. So this is a 99%. I mean, it's really bad.
More about the wiring.
Madam Dr. Kormakar for NICBD.
Oh, how are you? So nice to hear your voice.
Fine. You are doing a very challenging case. It is like a cheap cases.
Right.
Some of the audience is asking about the the size of the catheter, madam? Is 7 French?
Yes, yes, absolutely. This is a 7 French EBU without any side holes. So this is a 7 French, and since we plan to do a double stent strategy, a 7 French catheter obviously helps a lot.
Did you consider putting in a TPI before doing this procedure?
A tempered
Because it's a
piece
left dominant circulation, the RCA is
well,
small
actually,
in
you know,
size.
we've done more than 250 rotablations till date. And initially, when we were starting our rota program, we used to regularly put in a temporary pacemaker, especially when we would do a right coronary artery. But afterwards, what we did is we have 2 ampoules of atropine taken in a syringe, and the nurse just stands with it near the IV cannula. So as soon as she sees any bradycardia or anything, she just pushes it. And that's worked very nicely for us so far.
I think in terms of hemodynamic support, though, we would with an EF of 42, we would see what his blood pressure was. We do a right heart cath and keep monitoring that, looking for any elevations of the PAD and looking for a drop of cardiac output, and probably would get a second access here just to have it available.
A great suggestion. I really appreciate this suggestion. And actually his pressure, can we have the look at the hemodynamics? So this is his pressure currently, and he is not on any inotropes. So he's sort of maintained this pressure, but when we were like inflating or he would maybe drop his pressures, but we've tried so far to be as gentle as possible. And I think that is one of the keys also, to do the procedure as gently as one can, because these patients do not tolerate any kind of drop in blood pressure or any kind of arrhythmias or anything. So gentle handling of the pressure, wires, everything is very important. So can we proceed from the rota? So after rotablation, what we did is we did pre-dilatation. We wired the LED as well. So because we knew that we don't want to lose access to the LCX, that would be too hazardous. So we changed with a microcatheter to a Xion blue, the rota wired to a Xion blue, and then we wired the LED as well. Once we had both vessels wired, we did pre-dilatation of the lesion in the LCX with the NC balloon, 2.75 NC Euphora, and this is when his pressures sort of started dropping. So we went very rapidly up, and then we went down. So after pre-dilatation, now we could take our IVUS catheter. And you can have a look at what we saw. The IVUS severely calcified, almost 360 degrees of calcium, but we had managed to crack it a bit with the rota plug modification as well as with our NC balloon. So this is how it looks in the LCX. Severe superficial calcium, and then the ostia is also diseased, and then we went up to the left main, which was diseased as well. So here the catheter sort of jumped. So severe calcium. So once we had a look with the IVUS, we knew that yes, what we had presumed that we would be requiring a double stent strategy would have to be done. And so here we took onyx. We took a 3 by 30 millimeter onyx, and as you can see, it went very smoothly through that huge chunk of 360 degrees of superficial calcium. And after taking the stent into the LCX, we put a NC balloon, a 3 by 12 in the LED. So it was because we were doing DK crush, and then we deployed our stent. After deploying our stent, we removed the wire as is customary in the DK crush, and then we crushed our stent with the NC balloon. So we've crushed our stent, and this is one thing that I love about DK crush is because you don't need to use any dye. These are like steps, one step after the another, and you just look at the hemodynamics and the ECG, and you ask your patient how he is doing, and if everything is fine, the pressure is maintaining, the ECG is fine, you just go on doing the step one after the other, and it works really well for CKD patients. So here, as you can see, we were struggling a bit with the wiring, and then we managed to wire the LCX. Once we wired the LCX, we then proceeded, then proceeded to do kissing. So here one tip is that we try to save the wire. So this is a new wire that you always have to take. So what we do is, once we take the wire in, we push our fine cross or caravel or whatever, and then we change this wire, because then you can use this wire for rewiring again during the second, once you've deployed your second stent. So we change it to the older wire, and then we opened up the strut, and after opening up the strut, we did our first kiss. So after doing our first kiss, we again had to remove our LCX wire, and after removing the LCX wire, we went on to stent the LED. Now, obviously, to stent before stenting the LED, there was a lot of a tight lesion in the mid-LED, which we did pre-dilatation with. And we again had a look before deciding on the length of the stent, we had a look with the IVUS again in the LED. So you can have a look at the lesion that we saw in the LED. So fairly diffuse disease, and here also 270 degrees of calcium, superficial calcium, in some places 180, some places almost 360 degrees of superficial calcium. And then as we go near, you can see the crushed stent in the LCX. We're just going, yeah, and here obviously this is a CKD patient, so we can't use any dye. So we have, as you can appreciate, we've used minimal amount of dye till now. We've done our imaging with IVUS, and we have also taken shots as few as possible. So the left main was also pretty much diseased, and this is the left main with the stent. You can see the crushed stent in the from the LCX. We then went on, so this is the left main, which is pretty diseased. So we decided that we would be stenting from the ostia of the left main to the LED. And for this, we chose 3.5 by 38 resolute onyx again. And so the resolute onyx went very easily. And then we had to use a bit of dye now, because we were positioning on the ostia, so we had to focus on positioning in the ostia. So here
one thing you could have done is identify the ostium with the IVUS, sinnate it, and use that location, and you wouldn't actually have to use any dye to identify the IVUS, the ostium as well.
Great
Another
suggestion.
way to save dye.
I'll remember that the next time we do a kidney disease. Thank you so much. That's a great tip that we will definitely try to follow in the future. So we positioned our stent, and after we positioned our stent, we deployed it. Now, so we've deployed our stent, and this is where you have joined us. Oh no, we did something else. So we did a POT, proximal optimization, with a 4 by 12 balloon. And then, as there was a bit of time, we rewired the diagonal, but it's a diffusely diseased vessel. And we did, first of all, we did post-dilatation of the LED stent. And after that, this is how it was looking. So this is after deploying our stent from left main to LED. And as there was a bit of a time, we just wired the diagonal just proximally, because after that it was diffusely diseased, and we just opened up the ostia of the diagonal with a 1.25 balloon. But this was also quite a struggle to go in, but eventually with the help of a fine cross and a Sion, we could wire this vessel. So this is where you joined us. So now, basically, of the TK crush, what we now need to do is we need to recross into the LCX. And after this, we have to do the second case and then do the report.
Yeah, there is controversy. You potted already, whether you have to repot after the kiss.
Report.
I think the initial pot that you did is critical. But, if you do...
The report is optional, yes, absolutely. The report is optional, depending on how the IVUS and everything. And we plan to have a look with the IVUS as well. So now we are taking a fine cross with a Sion blue, And the idea is that we want to recross into the LCX.
What was the left main diameter?
The left main was 4 millimeters.
So don't you think you should have crushed the LCX stent with a 4 millimeter balloon, considering the fact that the left main was 4, and you normally need to crush it with a 1:1 size balloon, so that it gets crushed in a proper fashion, rather than crushing it with a 3 mm balloon.
We went to a very high pressure with the 3 millimeter balloon. So let's see, fingers crossed, and see how it behaves, right? And then we did the case, so first case, and then we deployed our stent.
You may not want to do a 4, you might not want a dissection at that point. Which may
Absolutely,
hurt
that
it
was
more.
our
At least
thought
I would do
actually.
at
We didn't
least a
want to
3-5.
dissect with a 4. That exactly. That was our thought. That's why we didn't do it.
Normally, what they say for proper crushing, you should slice the balloon to the left main by 1:1, so that the stent gets properly crushed. Proximal crush. Yeah.
Do you want her image again? That I was again?
Yes,
So was this-
that is the plan actually. So after we do our final case, we want to do a IVAS definitely to see what the outcome is and whether we would require to do a report or not.
So is this real time now?
Yeah, this is real time, please. This is real time. Okay, right. Yeah, because it was a
I
fairly
feel like I've been
complex
living in the
case.
past.
No. This is us doing the case. So, I mean, as it was a fairly complex case, and we knew that we wouldn't be able to finish it in half an hour, and the patient was
No,
also.
I think it's great. Don't
Dr.
apologize.
Fazila, do you believe that,
You're doing a fantastic job.
Thank you.
TAP would have been much easier in this case, complex case?
What?
It would have taken much less time, TAP?
TAP? Okay.
Yes.
The thing is, if you consider all the literature, DK crush sort of does the best results, right? So can we change this wire, please? I think this wire is a bit.
Good. Excellent.
Okay, so now catheter is in position.
I mean, there are still people who would definitely do a collot here. I mean, the vessel size are large enough. The nice thing about the Medtronic stents, they have a great expansion ratio. At the 3.0s and up, 3.5s up to certainly up to 4.0 at least. So that I think it's suitable also. Yes.
Just a minor comment. I just saw how the guide jumped a little bit in the left main. The longitudinal decompression of the see it a lot. We don't detect it, but it's there. But
well, in Excel, we saw it in high single digits. It was not uncommon.
Yeah,
and that's
so,
what the Zions also. They're supposed to have a low frequency.
I agree. But that's something to watch out whenever you have a stent in the left main. When you have your guide coming back and forth, you probably have to protect that motion with a balloon in front of you.
Yeah, and I think that's why you have to IVUS at the end. I mean, it's critical because that's the last place you want to deform stent.
I think DK crush has become more fancy, but an 82 years old male, and especially on hemodialysis, I think we would have opted for a shorter, faster procedure. And I strongly support that could have been done better, because this is a simple procedure.
Dr. Fazila, what would be your antiplatelet strategy?
Yeah.
Because he is the patient of the CKD with create.
What did you say?
Already got 2-time dialysis.
Yes.
What is the antiplatelet strategy? And what antiplatelet he has got already?
Antiplatelet strategy. Well, the plan is to keep him on aspirin and clopidogrel. Let's see how he tolerates that, and hopefully we would. So actually, just now, while we were attempting to take the wire, the microcatheter, we lost, the wire came out. So we are going in again. And then we will sort of do a balloon trapping rather than try to get it just with the inflation device. So that's the idea.
Do you think the intermediate wire would have been better?
No,
in this situation?
No, the wire was fine. It was just that the microcatheter came out. So the wire was all right. It was.
I think it's an interesting technique using the microcatheter because, frankly, unless I've had real difficulty crossing, I think most of the time, contemporary wires, especially the Xi'an series and the like, can get across all of these, especially with in a double kiss.
You normally take out the rotor wire when you're doing a pre-dilatation, when you introduce in the workhorse wire, and you normally take out the rotor wire when you're pre-dilating, or you?
Yeah, absolutely. We never do any work with the rotor wire except rotablation. We don't do anything.
Especially in this. As a matter of fact, I might have taken the wiggle wire down initially, just to get the.
My general practice is to leave the rotor wire when pre-dilating along with the workhorse wire, because first, these are calcified lesions. So when you have two wires in situ, it gives you extra support. Moreover, the presence of a rotor wire with the workhorse wire by force focus technique works like a cutting balloon. So it's always better to pre-dilate with the rotor and a workhorse wire both together.
Yeah.
So now we'll be taking our microcatheter. We're taking a balloon through the wire that is in the LED, and then we plan to just pull our microcatheter out because it didn't work with the inflation device.
Yeah, I mean, I'll generally just exchange over the rotor wire. With these type of cases, I don't want to, these patients can't take a joke. Any perturbation, these guys can crash. He has 3 vessels. Remember, he also has that tight, right? So, So, sometimes slower is faster.
Deflate, please.
Yes.
So now we have
balloon push me. 3.5.
Okay, so this is the balloon that we use to remove the microcatheter, and we will attempt to take it into the LED. Obviously, we'll have to be very gentle. If it doesn't go, we'll take another balloon. Because as you rightly pointed out, the ostia is covered with a stent, and we can't afford to be not gentle. So our balloon is not going, we'll just change it to another balloon.
And
one thing that I missed was, being a CKD patient and being 83 years of age, what was the baseline hemoglobin?
10.5.
10.5.
So why do you think the balloon is not advancing?
Well, you see, we've already used it to inflate and to pull out our microcatheter. So already we've sort of distorted its profile, and it was also previously used for post-dilatation of the LED stent. So the profile wasn't that great.
So that's a use. Yeah, well, one thing I do sometimes is just blow up the balloon in the guide and rewrap it, and you'd be surprised how often that saves the stent.
That's a good tip. Thank you.
It's all about saving time.
So this is
3.5 there. এত দূর না ম্যাডাম, বেশি দূর আছে। আরেকটু পুল করেন ম্যাম, একটু পুল। হ্যাঁ। Okay. Now going to the LCX 3.5.
Now we're going through the LCX.
3.5.
Both the balloons are 3.512.
Yeah. And the nice thing now with the LED, obviously, you have an anchor in there if you try to get across the circ stent, so that's very helpful as well.
L6. Catheter diameter. Good. L6 wire take to push করে দেন। Good. Okay.
So I think you could anchor
Wire entangled
with the distal if this is not going, and if not, just
LED
quickly go to a low profile balloon.
I think you travel
LED wire take to LED balloonটা push করে দাও। LED টা আরেকটু এটা আমি অ্যাঙ্কার করে দিই। হ্যাঁ, অ্যাঙ্কার করে এবার L6 দিয়ে দেন। L6
So now we've anchored with the. No, it's too proximal. Why don't you deflate it? It's too proximal.
Yes. Deflated. Yes. L6 right take to push.
Which is L6?
This one.
got entangled probably.
So now
এটা কোনটা
No, no, let's position our balloons properly first. So this is the LCX balloon and
this is LED
this is the LED. So now we are going to do our final case, please.
LED হ্যাঁ good
Yes.
2 4 6 8 12
Down, please.
down
Yeah. I
This
mean,
is the size
it
of
can
the
be
balloons.
helpful to do this sequentially.
Yeah,
All right,
it
a
can
very
be
high pressure, and then do a sort of a molding, afterwards.
Yeah, sometimes we do that.
Yeah.
What was the size of the balloons used for post
about
sanitation?
3.5
Both 3.5 by 12
12.
NC Euphora. Now we're using a 4 by 8 for report, I think, and then we'll just have a final look with the IVUS. Because you see here, one issue is that for this patient who has a high bleeding risk, I can't afford to have any type of stent malposition because and the vessels are heavily calcified. So I want to do my best possible effort
Over
and see
LED
how
wire.
it goes.
We're
So
going
the 4 by 8 NC balloon is now going over the LED wire, and we are going to just do the report proximal to the bifurcation.
Well, in excluding the renal issues, I mean, only problem with OCT is you're not going to get the proximal left main.
Yeah.
And
So-
that, so, I mean, we have done them if we're just, if we're not planning on covering the ostium, you can get some
L6
decent
L6.
data with good flushes. But, and there are some series now with left main and OCT. But for this, I think IVUS is the way to go. And also, I mean, there are other strategies you can do. I mean, Ziad from our group described this that we've done, virtually eliminating the contrast. But the key to eliminate the contrast in this patient, especially a hemodialysis patient, is get a baseline echo. Because you don't know, you will not know if there's tamponade, if he has a baseline effusion.
L6
You want to know if there's an effusion baseline, because you do the echo afterwards to make sure there's no proliferation.
আরেকটু push yes
There we are.
view ma'am
So we seem to be in position, and we'll do the report.
okay up
Make it a little further. You want to be at the ostium of the circ. Right?
কত 18 20
Negative.
view নাও হয়নি
So we went down.
হ্যাঁ একটু back ma'am a bit হ্যাঁ millimeter okay
And then
Going up,
clearly
eh?
do the ostium. There's been so much
View, ma'am.
manipulation
No,
on there.
I
We
hope
want to
we are
smooth
not,
out
yes.
any stent imperfections.
20
So we went up to 24 with a 4 NC. And now we'll take our IVUS catheter.
What dye you are using, Dr. Fazila, and how much dye you are using? Any plan to do dialysis today or tomorrow?
Tomorrow.
now it is midnight
So it's like 12 o'clock in the night in Bangladesh. So hopefully tomorrow early morning we'll do the dialysis. Our in-house nephrologist is aware, and
dye is
he's going to
very
be
much
very closely. And
Perfect.
up till now we've just used 30 mLs of dye. So fingers
30 ml.
crossed. And
LED হ্যাঁ এটা LED
this one's the LED.
LED L6 দুই দিকে আইপাস ইউ ক্যান আস্ক কোন দিকে যাব জিজ্ঞেস করেন কোন দিকে আইপাস নিব এখন LED না L6
So we're taking our IVUS through the LED, left main to LED. So we didn't sedate our patient, and as you can see, because of his CVD issues and all, and he's getting a bit restive, and he says that he wants to go to his bed. So hopefully,
But we all want to do that.
yeah.
But throughout this, his heart rate and blood pressure have been stable, correct?
Can we have a look at the blood pressure, please? Just hemodynamics again.
ক্যাথেটারটা একটু পুশ করে নিতে হবে
Because I can tell you in the U.S. there are physicians who would have unequivocally used Impella for this.
Impella, yes, that's why.
I'm not advocating. I'm just telling you that culture.
Good. LED white, man.
I think it wires back a little bit.
Yeah, I mean, I'm struggling with the IVUS catheter, right? Because there's this ostial stent, and I don't want to damage it. And obviously, I have to be as gentle as possible, and it's quite a struggle. When I push the wire sort of comes.
Go back with the sheath, it just makes it easier. This, type of unsheathed technologies can be very difficult in these complex calcified patients.
I'm struggling actually, because you don't want to cause any disruption on the stent, which is up till the ostium, and as soon as my IVUS catheter is going, it's sort of, I'm trying to push the wire.
They'll give dye and come out. No?
Yeah, well, it may be worth doing one more, real true ostial dilatation here, and then trying the IVUS again. I think it's important at least to identify at least the left main and bifurcation at the very.
No, IVUS won't even budge,
Guiding push, man.
So rather than do that, I would to get my balloon again. Yeah, get my balloon. Make sure it's hanging out in the ostium, so you flare it. And I think that if it's adequately sized,
so maybe we can do that. Maybe we'll do that. We'll take the balloon and flare the ostia. I think that's a great suggestion.
Exactly.
So we'll do that.
This is a good case because these are, the agony of the DK crush is perfectly expressed here. I mean, we do a lot of it, but I can't, and half the time I'm doing it, I ask why I'm doing it. It's a struggle, but the payoff is huge. I mean, I think in terms of the data sets, because I wish Antonio were here. I mean, he's a little delayed, but, he invented the crush. And we, it went through many iterations, and, we struggled with it for many years. And we sort of invented the two-stent controversy because the initial crush results were, not perfect. And the evolution of this technique now has made it, if you believe it, the preferred treatment for a double, 111 bifurcations in the left main. But we'll see. Is the British study enrolled yet? Carlo, for the left main bifurcation.
I think I'm going to remove the L6
Is that enrolled yet?
and see whether that helps me in taking the
EBC bifurcation. So anyway, they will have comparison. Yes.
I think the SpO2 is low. Is about 80. Or they are going to do anything about the oxygen saturation of the patient?
Yeah, you want to see the, it's 100%. Can you go to the, please go to the,
Are to push, man?
yeah, it's 100%.
To push, man. Middle to push.
Yeah, the 84 is the heart rate.
Catheter push, man. 18-20 চলে আসেন না
Yeah, do it in hanging into the aorta.
No.
Do you want to do proximal flare up of the LMC ostium?
We did.
Or Fazila, we did, no?
Yeah, we did.
All right, take advantage of your guide position now, and let's see if the IVUS goes.
Catheter.
Should not use.
So our patient just sort of, he got the sheath out. So someone has to hold that, yeah. Because as I was saying, he was getting a bit restive, and so the, yeah, so.
আপনি চলে যান এটা ঠিক আছে everything okay.
Well, if you're having access issues, I would not necessarily persist with the IVUS right now. I mean, we're talking about high bleeding risk. Well, here we have it. He's bleeding. So if you if you can control it easily, fine, but don't feel pressured to do the IVUS.
So we are in with the IVUS now. We're in with the IVUS, so let's go for. Yeah, so our stent looks pretty well opposed, as you can see in real time, and we're doing a manual pull back gently, slowly, and that's. So our stent is nicely opposed, considering the amount of calcium he had. So this is the bifurcation you can see. So you can see our stents are very well opposed, and both lumen look fine, and you can see the LCX stent in the 6 o'clock position.
Yeah. It's probably worth getting the minimum stent areas.
The left main.
So this is the left main.
Left main looks very large.
Yeah, and that's us out.
It does, and it looks like it nailed the ostium, and there's no distortion of the stent, so
Yes.
you're great.
So we'll do, we'll take an angio shot, and then we'll call it a day.
I mean, the only reason to do the angio shot now is honestly is to look for perforations or side branch occlusions.
Right. So we'll do that. Fingers crossed.
I don't do zero contrast. I always do one last shot.
Yeah.
even if
So
I use
we'll do that.
virtually
Which
no
view do you
contrast.
want us to take it from?
No, ma'am.
Yeah. So we're in position. So let's.
So make sure you have the entire heart on the screen so you see all the distal
Yeah,
branches.
we'll do that.
Wires have been a lot of places, and we sometimes forget about them.
So, yeah. So we have yes.
Sir, any scope of dedicated bifurcation in stenting in LMCA?
Pardon?
In LMCA bifurcation stenting, any scope of dedication bifurcation stenting?
So this
Dedication?
was our spider
yeah.
view, and let's have a final. So this is yeah.
You look great.
Okay, let's go to the epicranial, right? So we'll take a final shot in the epicranial view and make sure there is nothing wrong in the LAD territory as well.
I mean, a drug-coated Triton right
So
now in the U.S.
that's the LAD.
It would be a drug-coated Titan.
And we finished with 50 ml of dye, less than that because there's quite a bit in the tubing. So we just used 150 ml of Visipag. 150 ml small bottle, so, and the entire DK crush is finished. So that's our patient, he's stable. We can have a look at the hemodynamics. So he 100% saturation pressures are maintaining on no inotropes, and let's have a final look at the final shots please again. So this is our spider view. This is
So how long do you intend giving the dual antiplatelet therapy to this patient?
Oh, the antiplatelet therapy, we want to keep it simple and give him aspirin and clopidogrel. And considering his CKD status, I mean, you know about the Onyx 1 trial, they could stop in high bleeding risk patients within a month. So that is a reassuring fact that we know that if need be, I would try to continue the dual antiplatelet at least for 3 months, but if the need should arise that I need to stop it, I can safely stop it because evidence states that it's safe in high bleeding risk patients like this to stop if you're using Onyx 1. And we saw by IVUS that our stents are well opposed. There's no stent malapposition. So that is also a reassuring fact that there is not, hopefully, touch wood, not much risk of stent thrombosis. So it's a fine balance, isn't it? You don't want them to bleed, but you also don't want to end up with a stent thrombosis. So
thank you, madam. It is very appreciating result at the end of the case. So it is a very challenging case. 83 years old, repeated dialysis, the repeated 2 times CVD, and the triple vessel disease with high CT score, and we have did the case is very excellent and with very low dye congratulations again.
Thank you so much, and thank you for giving us this opportunity. We are very grateful. Thank you.
Thank you.
Thank you. And that's the team, photo of our team of National Heart Foundation Cath Lab. So everyone did such a tremendous job, and thank you to the entire Cath Lab team. Thank you.
This is one of the effective team, efficient team of Bangladesh. And again, thanks to Professor Fazila Madam.
Thank you. Thanks.
Thank you very much for this nice case. My comment quickly is, this is a patient who is at high bleeding risk, but at a high ischemic risk at the same time. I mean, none of his arteries, branches everywhere is full of atherosclerosis. So my question is, why subject this patient to the variation of the clopidogrel response and not using a more potent antiplatelet? I'm keeping in mind the high bleeding risk. I'm not, I mean, I would personally use one of the new antiplatelets, especially if I'm planning on doping the aspirin like in 4 weeks' time.
So that's a suggestion.
Yeah. I mean, I think it cuts both ways. I mean, I think doing a PRU, doing a platelet assay on the Plavix would be my
He's
first
82
choice.
years old.
Yeah.
Yes.
No, there is clinical benefit if you're deciding between a more potent one and this, because if you have good inhibition with clopidogrel, you probably do just as well as you do with one of the more potent ones. If you're concerned about the high ischemic risk, I mean, rather than just putting them on ticagrelor initially, I'd rather do it that way. I think there still is a place for that when you're making these type of decisions. I mean, there's no clinical benefit overall because the event rates are so low. This is not a low event rate patient. This is more, and he was an ACS. He was a non-standard. We're done? Yes. Okay. So we're moving on. We're still live here, but are we moving on to our talks now, I think?
Yes.
Yes?
So thank you for giving us this opportunity. Thank you.
Oh.